Dr. Munguía Rodríguez Aarón Giovanni. He's presenting from Mexico. He's going to present, this is a flash presentation on trigeminal neuralgia secondary to a giant osteoma. Thank you, sir.
Thank you, Naren.
Thank you.
Well, my name is Aarón Munguía. I'm going to present you a case report of trigeminal neuralgia secondary to giant osteoma. We are from Hospital Angels in Morelia, Mexico. We are specialists in treating trigeminal neuralgia, which is a chronic disorder characterized by spontaneous and recurrent episodes of neuropathic pain, generally affecting one side of the face and involving one or more branches of the trigeminal nerve. Based on the etiology, trigeminal neuralgia is classified into idiopathic with an unknown cause, classic when a nerve is compressing the root and trizone of the nerve, and secondary when it's caused by an underlying disease, such as tumor or multiple sclerosis. Osteomas are slow-growing tumors characterized by the proliferation of compact or cancellous bone. Osteomas are benign tumors of long bones that might uncommonly arise from the skull in the frontoethmoid region and rarely from the temporal and occipital bone. They are incidentally identified. Complications derived from the osteomas are due to the involvement of surrounding structures. When the tumor affects a nerve, compressive neuropathy may be developed. The case presentation. In April of the last year, a 37-year-old female presented with severe paroxysmal pain of 3 years of evolution of the right side of the face, radiating the territory of the B2 and B3 branches of the trigeminal nerve. The pain progressively worsened until it became incapacitating. MRI showed a hypointense mass located in the inner side of the petrous apex in the right temporal bone with an irregular multilobe shape measuring 20, 36, and 40 millimeters extending to the right cerebropontine angle. In the blue arrows, we show the tumor. In the green arrow, we show the trigeminal nerve in its normal path. And in the red arrow, we show the trigeminal nerve displaced by the tumor. Angiography revealed a lesion with bone consistency displacing intracranial structures. The tumor is delimited by a red border. No blood vessels were identified supplying the tumor, and the right superior cerebral artery was interrupted by the tumor. It is shown in the green arrow. Its circulation was possibly replaced by a duplicated upper right anterior inferior cerebral artery. The duplication is indicated with the yellow arrows. The surgical technique, minimally invasive microsurgical decompression surgery was performed with a retrosigmoid craniectomy of 20 millimeters. An abnormal osseous structure was identified in the right cister. The bone lesion was interfering with the clear identification of the trigeminal nerve and facial vestibulocochlear complex. Here we show that only the trigeminal nerve was affected by the tumor. Osteoma was progressively dried, avoiding to damage adjacent vascular and brain structures. Due to the high risk of causing a neurovascular damage, it was decided not to remove the osteoma completely. The trigeminal nerve was identified anatomically intact in its external path, and exploration was performed in order to verify that there was no hidden vascular conflict. The results. After the surgery, patient was neuropathic, pain-free, and neurologically intact. No alterations in hearing and facial functions were informed. Here we show a preoperative computer tomography where the osteoma can be clearly identified. At 3 and 9 months of follow-up, the computer tomography revealed that no growth of the osteoma was observed. At 18 months of follow-up, the patient remained asymptomatic for trigeminal neuralgia. Histologic examination reported a benign lesion characterized by the formation of mature trabecular bone with absence of osteoblast and osteoclast. It's important to highlight that only patients with symptomatic or deforming osteomas should be treated generally by tumor excision or drilling. Periodical imaging tests, audiometric evaluation, and clinical observation are necessary in order to exclude recurrence. Our conclusions: despite its low incidence, osteoma of petrous bone should be considered as a cause of trigeminal neuralgia. To ensure pain relief, the osteoma must be drilled carefully without damaging adjacent structures, in addition to verify that there is no neurovascular conflict. Trigeminal neuralgia secondary to osteoma must be diagnosed after a correct clinical, radiological, and pathological evaluation. Thank you.